Hello, everyone. My name is Dr. Michael Mamone. I'm an internal medicine resident with Florida Atlantic University. My co-authors are Dr. Kyle Gordon and Dr. Hadir Sanawi. My topic presentation is endoscopic balloon dilatation, an emerging treatment option for cricopharyngeal dysfunction. A little background on the case is that inflammatory myopathies are characterized by weakness and chronic inflammation of skeletal muscles, and the weakness of the pharyngeal muscles may occur in advanced cases of inflammatory myopathies, which ultimately result in dysphagia. Now, currently, the management of cricopharyngeal dysfunction is typically a surgical myotomy or botulism toxin injection. However, recent emerging data shows that endoscopic balloon dilatation is a safe and therapeutic option for these patients. So, moving on to the case presentation, this is a 78-year-old female. She has a past history of polymyositis with resultant severe upper and lower extremity weakness, osteoporosis, sarcopenia, and polymyalgia rheumatica, who presented with worsening dysphagia to both solids and liquids. The dysphagia was worsening over the last 1 to 2 months to the point where she was no longer able to swallow any form of food. Speech pathology evaluated the patient and underwent a modified barium swallow, and this showed a weak pharyngeal constriction with deep laryngeal penetration. Interventional gastroenterology was consulted, and she underwent an upper endoscopy, and she was found to have a hypertonic cricopharyngeus. And this was managed with endoscopic salivary dilation to 20 millimeters, and following this procedure, the patient had significant improvement in her symptoms. Now, moving on to our figures here, in the center of the screen, you'll see figure 1. On the left-hand side, we see a hypertonic cricopharyngeus muscle. On the right-hand side, we see a cricopharyngeus seen after balloon dilatation. You see the significant improvement following that intervention. And in figure 2, we see a hypertonic cricopharyngeus undergoing balloon dilatation. So a little discussion on the case is that inflammatory myopathies are a group of autoimmune diseases with inflammation of the skeletal muscle. The oropharynx and proximal esophagus actually consist of skeletal muscle tissue, which is why we have resultant dysphagia in these inflammatory myopathies, because they have involvement of the swallowing muscles. Now, dysphagia, as we all know, can lead to complications such as nutritional deficiencies, failure to thrive, aspiration pneumonia, and overall decreased quality of life as these patients are unable to eat their favorite foods. Dysphagia in those with inflammatory myopathies can be accurately assessed with a flexible endoscopic evaluation, as well as a modified barium swallow. Repetitive swallowing as a spontaneous compensatory mechanism can improve bolus clearance and decrease the risk of aspiration. However, current management of cricopharyngeal dysfunction includes surgical myotomy and botulism toxin injection as mentioned previously. And there's been significantly recent studies that have shown that upper esophageal sphincter dilation by either static or retrograde technique is a safe and effective way to manage cricopharyngeal dysfunction. And this is an emerging field and may need to get more involvement from the gastroenterologist to consider this therapeutic option for our patients. Now, in conclusion, the esophageal skeletal muscle involvement in those with inflammatory myopathies is the etiology of the dysphagia commonly seen. Dysphagia has an increased risk for failure to thrive and aspiration pneumonias. Cricopharyngeal dysfunction can be evaluated with flexible endoscopy, and endoscopic balloon dilatation is an emerging intervention. It's safe and effective for management of cricopharyngeal disease. My references are listed at the bottom right. Thank you so much for listening to my presentation. Have a fantastic day.